Assalamu alaikum everyone. This is Sidra Azhar, roll number EP1770144, fourth prof evening. The topic which I'll be presenting today is pediatric nutrition, and the subtopic which I have been assigned is parenteral pediatric nutrition. So first of all, what is nutrition? Nutrition is basically the science that interprets the interaction of nutrients and other substances in food in relation to the maintenance of growth, reproduction, and health. Pediatric nutrition is basically adequate nutrition, which is fundamental to the growth and development of infants and children. And it is responsible for the reduction in infants' mortality in the world. Breastfeeding is one of the most important way for feeding an infant of 1 year of age. But if this fails, then we have a wide variety of infant formulations available. Secondly, balanced diet is needed for children for the growth and development. The decrease in balanced diet may result in malnutrition. Malnutrition means poor nutrition, which is a leading cause of child's mortality. About 45% of deaths worldwide are related to malnutrition. India has recorded the highest number of deaths of children under 5, and about 50% of them are linked to malnutrition. So, poor nutrition is a cause of various childhood diseases. Then we have some concern of the pediatricians and pharmacists. Some complaints that actually signal unhealthy dietary habits of children, and they may cause for common ailments that are found in children. These ailments could be vitamin deficiencies, anemia, a raise in the cholesterol level, gastrointestinal diseases, some dental problems, some problems due to obesity like hypertension, diabetes, osteoarthritis, and it could also lead to poor growth, which may result in stunted growth. Now, basically the provision of appropriate nutrition is one of the greatest importance in infancy and adulthood. A decrease in pediatric nutrition can cause respiratory distress, GI abnormalities, chronic and renal hepatic failure. Some infants with GI abnormalities require pediatric nutrition because of the implantation of the internal feeding in them is very delayed. Despite of many formulation and feeding techniques, several medicines and GI dilemias arises in infants that limit the use of GI tract for nutrition. So for this case, we have the best thing is to use parenteral route. So now coming towards the main topic, which is pediatric parenteral nutrition. It is a safe route. The long-term parenteral nutrition was first described in infants in 1972. The indication for the pediatric parenteral nutrition is limited to those children whose GI tract is inadequate to support normal growth and development. Parenteral nutrition should be used only when it is not possible to meet the nutritional requirements via the GI tract or when there is bowel dysfunction, resulting in inability to tolerate internal nutrition for a prolonged time. 1 to 3 days in infants and 4 to 5 days for children and adolescents. A condition arises called as gastroschisis. This is a GI tract abnormality. It is basically a birth defect in which the baby's intestine extend outside of the abdomen through a hole next to the belly button. The size of the hole is variable. In this case, the ileus is operated, and because of this post-operated ileus, TPN means total parenteral nutrition is needed in all infants with gastroschisis. The main cause for the healthy recovery period is the time taken for infants' bowel function to return to normal. After surgery, infants are fed through IV fluids and gradually introduced to normal feeding. The rate of gastroschisis increases when the bowel function is decreased, and it could be fatal if it is left untreated. In regard to this, we have a picture which is showing the abdominal wall is open. You can see the abdominal wall is open, and the abdominal organs are lying outside the belly button under the uh, under the gravitational forces. Now coming towards the case study related to the gastroschisis in infant. The case is that there is a male patient, a full-term male infant who was born during a normal vaginal delivery, and he is and admitted and the patient is admitted to the pediatric intensive care unit with gastroschisis. He was the second child of a 20-year-old single mother who did not attend antenatal care but who reported no problem during pregnancy. She did not use any vitamins or mineral supplements before or during pregnancy and reported no smoking or use of alcohol during pregnancy. Anthropometry on admission was estimated. Patient's birth weight was 2.4 kg, his length was 45.5 centimeter, and his head circumference is 32 centimeter. So the question is that how would we manage the total parental nutrition for the patient? So in regard to this, I have prepared some soap notes. Now coming towards the subjective, we have given the birth weight of the patient, which is 2.4 kg. The length is 45.5 centimeter. Gender is male. Head circumference is 32 centimeter. The patient is diagnosed with gastroschisis with mild birth asphyxia. The history is that the 20-year-old mother of infant did not use any vitamins or minerals supplements during or before pregnancy and reported no smoking or use of alcohol during pregnancy. The objectives are that the patient was intubated, ventilated, and a central venous pressure line inserted. The gastroschisis was covered in a silo bag and suspended above the abdomen with gravitational force. After 3 days, the ball has been reduced sufficiently for the patient to undergo surgery for the closure of the abdomen cavity. The wound was closed under pressure, resulting in two vertical line incisions to allow skin closure over the gut. Now, in the next few days, the patient may develop respiratory distress and bacterial meningitis and could have several episodes of convulsions. The patient could not be weaned off the ventilator and stayed on TPN until he passed away. The assessment are that due to intubation and ventilation, the patient required total parenteral nutrition through large veins in the belly button or the umbilical vein. The plan is that it is recommended that the standard polymeric formula could be used when initiating internal feeding in most patients. The nutrition calculation were undertaken using the European Society for Pediatric Gastroenterology, Hepatology and Nutrition. Here we use ISFIGAN 10 recommendations for TPN in neonates, and TPN was started initially. Then it was increased gradually over a period of 5 days until maximum parental intake of 150 ml per kg was reached. It was kept at this rate for a period of 3 days, when it was reduced for 24 hours due to suspended sepsis, and then increased again to 150 ml per kg. Then after surgery, the plan was to start the patient on a semi-alimental infant formula and wean him off TPN gradually. In some cases, prolonged TPN is often needed, as intestinal motility impairment can be a constant problem and the return of GI function can take several weeks to months. Now, coming towards the conclusion that successful weaning of TPN and establishing full internal feeding is a difficult task for the dietitian for such patients. However, the medical nutrition therapy for patients with gastroschisis as well as optimizing the nutrition status of women of childbearing age should be an important consideration for the dietitian. I hope you get all my points and everything is quite clear. Thank you so much for listening. Jazakallah.